Good afternoon, everybody, and welcome to Care Fertility. I've just made the journey across from Liverpool to our training lab here in Manchester. The weather's very similar to what it was in Liverpool, and it only took me 40 minutes, so that's good. My name is Charles Kingsland. I'm the Professor of Reproductive Medicine. I work at Care. We are still in lockdown mode, so we're seeing patients not routinely by face. We're actually conducting interviews by Skype, by telephone, but there are one or two selected clinics where if you would like to see the doctor or the nurse face to face, like for example in Liverpool, we're doing consultations, and we look forward to seeing you there. This video. Oh, hello, Zita.
Hello,
Zita's
how
here.
are you?
Our world-renowned nutritional therapist at the Zita West Clinic in London. I'm fine, thanks. Are you?
Yes, fine. I like your trendy glasses.
Yes, do you know what? I'd lost my glasses. I just said to Matilda, oh, crikey, I can't find my glasses, and they're here. So that's the aging process for you, I'm afraid. But yeah, so just before we start with the questions, I'd like to remind everybody who's watching in that we're going to save this on video, and you can watch back on Instagram, Facebook, or YouTube. So for the next half an hour, we'll be chatting about all things fertility. We'll be answering any questions that you have, but we wanted to concentrate, if we could today, on very common conditions that we see all the time, and address some of the issues that they present, particularly with reference to fertility. Those two conditions are endometriosis and polycystic ovarian syndrome. I'm sure that many of you who are watching today have already been made the diagnosis, and that's why you're watching. But for those who don't, endometriosis it can be a really nasty problem, and it's where the endometrium, the lining of the womb, grows in places where it shouldn't be growing. So there's lots of theories as to how it starts, but one of the commonest ones is that instead of when you have a period you menstruate downwards and outwards, some women actually menstruate upwards and inwards, and so the menstrual fluid, or the endometrium, actually goes up through the fallopian tubes and then settles in other places in the abdomen and gets its own blood supply and its own hormonal supply, and then at times when the hormones are in menstruation mode, those little spots menstruate as well, and that can cause a lot of problems. Mainly it can cause pain, it can cause quite nasty debility depending on where it is. If it's in your bowel, it can cause rectal bleeding and pain. I've actually seen it behind a patient's eye, and every time she had a period, she went blind in one eye. But really, for the purpose of today, we're talking about when it affects the lining of the womb, or the pelvis itself. Now, it can settle in many places in the pelvis, behind the uterus, actually in the wall of the uterus, on the ovaries. It can cause growth in the ovaries, which are called endometrioma, and it can actually cause blockages in the fallopian tubes. But even when it's very minimally affecting you, there's an association between minimal endometriosis and difficulty in conceiving. And the theory as to why that happens is very spurious. We don't know, but there is a connection between endometriosis, even when it's very minimal, and infertility. And it might be mediated through cytokines or various hormones, or it might be the fact that it prevents implantation of the embryo. But it can be a problem, and it can cause infertility. Obviously, if it blocks your fallopian tubes, then there's a mechanical reason why it's causing fertility. But often it doesn't, and we just don't know the real answer. Do you see much endometriosis in your clinic, Zita?
Yeah, we do. And it's very hard for women because they're always, they don't know. The questions we get asked all the time is, what should they be doing before they head down an IVF route about their infertility? And there's a lot of mixed messages that go on here for women. So I don't know what your views are about endometriosis prior, what investigations you need to do prior to doing IVF.
Well, quite often when patients come with a fertility problem, they will give some signs in their history
Yeah.
that they may have endometriosis, like, for example, pain around a period time, heavy period, or symptoms that might be attributable to endometriosis that is remote from the pelvis, like
Yeah.
rectal bleeding and a heavy period. There's actually very little evidence to suggest that treating the endometriosis can improve your chance of pregnancy whenever, particularly when it comes to IVF. Obviously, if you've got a great big endometrioma on your ovary, you know, that needs to be treated prior to your IVF, because that can cause lots of problems. But generally, there's very little evidence to suggest that treatment.
Yeah, and I think that's
will
reassuring to women. I think that is reassuring, definitely for women. But
Yeah.
what we look at as well, Charles, we look at nutrition, because endometriosis does cause an inflammatory response in the body. So, you know, looking at supplements such as omega-3, which help with inflammation, looking at cutting out foods, processed foods, trans fats, alcohol, exercise, you know, things like that can be or may be beneficial, but definitely an anti-inflammatory diet and cutting out pro-inflammatory foods, like I said, trans fats, processed foods, etc. And women do want to feel they're doing everything they can to prepare for IVF, if they've, you know, whether they've got endometriosis or whether they don't, they want to feel they're doing everything.
Yeah, but even with something like endometriosis, lifestyle changes are so important.
Yeah, absolutely, absolutely.
So many times patients will come to a clinic with, you know, with endometriosis and say, look, what can I do? There are specific therapies that can treat endometriosis. For example, if you stop the bleeding, if you stop your menstruation, then you can't, your endometriosis in theory will shrink away. But of course, a lot of those treatments are contraceptive, and that's not what we want. The best treatment of the lot is pregnancy, and that's what we want to achieve. But generally, lifestyle changes, weight is so important. And I'm surprised that it's taken all this time for COVID and now Boris Johnson to say, well, actually, weight, being overweight is not good for your health. Well, it's certainly not good for your health. It's not good for your fertility either. So, and stopping smoking. I know I keep going on about this, but so many times patients will come along to the clinic with lots and lots of nutritional additives, but they still smoking 10 cigarettes a day. So you must stop smoking. Lifestyle is important. And what are the additives that you would recommend in particular before you start?
Supplements?
Yeah.
We would use a lot of omega-3, but you know, it's quite interesting. There's so much more now known about the gut and like the microbiome. And I did an interview with a doctor from the States last week. And again, gut health matters as well. You know, getting rid of excess estrogen from the gut, you know, doing a detox, taking fiber, anything that's going to clean the gut up can help with the inflammation that endometriosis causes.
Yeah,
but you are right. Weight does have a big impact on endometriosis and fertility.
Yeah, and also preparing. It's just that concept of preparing yourself for fertility.
Yeah,
it's really important. There's a question here from Sam Robinson. How soon before treatments should I take supplements?
Well, a lot of our women that come, you know, we refine their supplementation, but usually you're looking at about 2 to 3 months before you start treatment if you've got something like endometriosis to start taking supplements. But, you know, what I want to be really clear about as well is that supplements will help, but they're not going to get rid of the endometriosis. It depends on what stage the endometriosis is at. So some is much worse than others, isn't it?
There's a question here. Do I need to have endometriosis removed, remove my cysts from the ovary via surgery before proceeding to IVF? There are lots of important factors with regard to successful outcomes in IVF, nutritional therapy, preparing for your fertility. But generally, if your endometriosis is severe, it might be worthwhile addressing that surgically or medically before you go for your IVF. I know I've just said that there's no real evidence that that's going to help, but clearly if there are large endometriomas, it's not going to do you any harm to have them removed. The factor you have to take into consideration though is your age. Age is as important, if not more important, than the endometriosis. So if you're 38 and you have endometriosis, then you have less time to consider treatment and then come back for your IVF than if you're, say, 30. And if you're 30 years old, you've got extensive endometriosis and you get a lot of pain, then and a lot of people, it would prevent them having sexual intercourse because it's so painful, which of course is a contraceptive in itself. So you might have more time to have the endometriosis surgery. So I think it's well worthwhile speaking to your fertility doctor as to give you advice as to whether you should have the endometriosis treated before or after any particular therapy.
And I think if a woman has heavy bleeding as well, Charles, iron is really important, you know, iron-rich foods and things like that, because that depletes your system as well before you start. Yeah.
Are my chances of successful IVF reduced to my polycystic ovarian syndrome and endometriosis? Polycystic ovarian syndrome is another very, very common condition that we see in the fertility clinic. I would say as many as 50% of the women I see with ovulatory problems will have polycystic ovarian syndrome. Now, polycystic ovaries, in a nutshell, is where you have lots and lots of eggs in your ovaries that are not ovulated. So you get lots of tiny little cysts with eggs that have been matured but have not been released. So you get poly, which is lots of, cystic, tiny little fluid-filled sacs with eggs that you occasionally ovulate. Now you've got lots of eggs at varying stages of maturity which have not been ovulated. And of course, if you don't ovulate, you're not going to be able to fertilize your egg. So that's one of the common conditions, but it's a syndrome. And anything that's called a syndrome in medicine means that it has a spectrum of symptoms. Either it can be very, very mild, in which case you don't even know you've got it, or it can be very, very severe. The first case of polycystic ovarian syndrome were described in the 1930s, and these were hugely overweight women with unwanted hair and no periods and infertility. That's right at the very end of the spectrum, and it doesn't mean to say that you're going to move from one to another. Usually you stay where you are, but fertility is usually related to not releasing an egg. And the major problem with polycystic ovarian syndrome, surprisingly, is an abnormality in the hormone insulin. Now, insulin is the hormone that metabolizes sugar to give you energy. When you're a diabetic, you've got no insulin, very low levels of insulin, so you can't metabolize sugar. So eventually, in theory, you could drown in sugar. In polycystic ovarian syndrome, often you've got too much insulin, and the insulin is very effective at metabolizing the sugar, but unfortunately, you don't have enough time to use the energy, and the spare metabolite is glycogen, which is a fat-type material, which you then store, usually around your middle, and so you get unwanted fat. And this is where girls with polycystic ovarian syndrome have a problem with weight. And I would say one of the biggest issues that we have with polycystic ovarian syndrome in the general fertility clinic is girls having difficulty getting down to their right
BMI.
weight. To get their BMI, your body mass index is your weight in kilograms divided by your height in meters squared. It should be between 20 and 25. And often these girls have body mass indexes which are above that, sometimes well above that, and that affects their fertility. And it's usually very difficult to get that weight down. But I'm going to ask Zita, what's the magic nutritional formula to lose weight with PCO?
It's really hard, but I think as well, I think that for a lot of women, they really worry when they've been diagnosed with PCOS that they're not going to be able to get pregnant. And I think many women with PCOS do get pregnant. And you don't have to be just overweight. You can have lean PCOS as well, where you're underweight. But I think the thyroid is often neglected here as well, because there is a link between the thyroid and PCOS. So I think that it's, you know, proper investigations. Exercise is really important, especially resistance training, because you're trying to you know, get rid of muscle and fat. I think diet is important. So blood sugar balance and managing your blood sugar is so key in all of this. Supplements such as myo-inositol, they've got studies to show that they help with regulating a period, but they also help with weight loss and they help with insulin resistance. So it's looking at everything. And I think for many of the women that are overweight, what's hard for them is they lose confidence, they have low self-esteem because they are doing everything they can to lose that weight. So I think there's a lot of emotional connotations here that need to be looked at for those women. Because they can't access a cycle on the NHS if their BMI is 30. Privately, it's around 35. So it's really hard for them.
Yeah, and women with PCO often feel alone, but it really is very common.
Yeah,
and it's a common disorder with common symptoms, and we can treat it.
Yeah.
How will my IVF treatment be different if I have PCO or endometriosis? Well, often if you need IVF, because conventional therapy for PCO hasn't worked, and that can occur because girls with PCO or moderate severe PCO can often be less fertile than normal for the reasons we've given. But the problem with IVF with PCO is that the women tend to have a lot of unruptured eggs, and so when you stimulate a patient, they often produce lots and lots of eggs with a varying maturity. So we have to be careful in any conventional IVF program that you don't overstimulate, because that could cause something called ovarian hyperstimulation syndrome, where the ovaries go berserk and you produce lots and lots of eggs. So you have to be very careful about the about how you stimulate girls with polycystic ovarian syndrome. But like all other fertility problems, age is very important, and the prognosis for girls who are of not too overweight, as you've said, Zita, with IVF with polycystic ovarian syndrome, is actually very good, and it's very common, so it's not unusual. Endometriosis is a little bit different. Again, age is very important. The extent of the endometriosis is important, whether it's damaged your eggs because by the menstrual fluid seeping into your ovaries, that's important. But simple tests at your fertility clinic can easily assess what we call your ovarian reserve. There's a test called anti-Mullerian hormone, which is a hormone that's produced by the little cells that surround the eggs. It doesn't tell you about the quality of the eggs. Your age tells you about the quality of eggs more than anything, but it tells you about the numbers. So that is a test that may be worthwhile doing just for reassurance, and it gives you an idea as to what your egg reserve is and potentially what your likely outcome is, so that the doctor can give you a reasonable idea about your chance of success, but also importantly how much time you've got left to undergo that treatment. Would there be anything else that you would say, Zita?
I think it's harder sometimes with the anti-Mullerian hormone if you've got PCOS, isn't it, to get an accurate reading. So, you know, you need a proper diagnosis. But I think as well for women with PCOS with irregular cycles every 40 or 50 days, they limit their chances of getting pregnant in a year. So for them, they don't want to go straight down the IVF route, but there are other things like you were saying that you can do as a first line of treatment if you're younger to try and make them ovulate. So, you know, Clomid and various things like that may be useful before they go down that route. But again, you know, for me, it's looking at holistic approach, and exercise and all of this comes into it.
Yeah, and I just say again, weight is also very important. But don't, for goodness sake, if you do have weight issues, and sometimes for girls with PCO it can be difficult to lose the weight, don't feel alone. Ask for help, and there are plenty of people who can, or your fertility clinic can point you in the right direction, or a specialist clinic like Zita in London could give you the nutritional therapy that you will benefit from. IVF, is there any difference between short and long protocols for endometriosis? When we talk about protocols, we talk about, this is the hormones that we use to stimulate the ovary to produce lots of eggs to enable us to collect them and fertilize them and create embryos, which is an essential part of the IVF process. Some would say that a long protocol where you switch off the patient's hormones for a longer span of time in endometriosis will have a benefit, and that in some cases is probable. However, I wouldn't say as a general rule of thumb the long or the short protocol of stimulation has any particular benefits one way or the other. There are advantages to the short protocol, i.e. it's short, whereas the long protocol takes much longer. Your hormones are depressed much further, and so theoretically your own hormones are not playing a part. But whether that's a benefit or not, I wouldn't necessarily think so. If you have a mass scarring and damage to endometriosis, can this lessen your chance? It depends where the scarring is. Generally speaking, no, it shouldn't, because what we're trying to do is to put an embryo safely into your uterus, and your uterus is spared all the scarring. The scarring happens on the outside of the uterus, but there is that strange phenomenon association between endometriosis and a slight reduction in implantation for reasons we don't know. So the pregnancy rate is slightly lower, but not significantly lower, and the scarring doesn't necessarily affect it, unless of course it affects your egg producing mechanisms in your ovaries. Would you say, Zita, is there any supplements that patients should be taken if they need IVF and they've got endometriosis over and above what you've said?
Yeah, and yes, and also endometriosis and PCOS is vitamin D. I mean, women with PCOS have got lower vitamin D levels, so I think that's really important to look at vitamin D, especially if you're Black or Asian, because it is likely to be lower. And vitamin D as well is the workhorse of the immune system, so it's very, very important for the immune as well. So that's what I would suggest. But I think as well, different nutrition needs are required for different conditions. So it's not just about going and just taking a couple of supplements. It's going and getting nutritional help, so it can be individually tailored to you. But the women with endometriosis that have very painful periods and heavy periods, that's really debilitating as well. So it's about building them up. Things like acupuncture may be useful because it can help with pain and beta endorphin release. So there are things that you can sort of look at outside of the medical side to help support you.
And what about omega-3? I know there's a lot about fish oils and
fish oils are really, really important. And again, if you're vegan or vegetarian, there are different oils you can get that don't contain fish. They're from plants. But I think omega-3 is really, really good for it's an anti-inflammatory, so it's excellent for inflammation, it's excellent for immune. It's hard to get the right amount from your diet, so supplementation is a good thing to do. And for PCOS, I think myo-inositol, and lots of doctors now use myo-inositol, don't they, to sort of help regulate cycle. It helps mature eggs in polycystic ovaries. It helps regulate cycles. And I'm a big fan as well of Coenzyme Q10, which lots of women take for their eggs when they're going through IVF.
Yeah, I saw a patient in Liverpool yesterday who came in with her Zita West Q10, and she said, should I be taking these? And I said, if Zita said so, then that's good enough for me. Are PCOS and endometriosis patients at higher risk of miscarriage? No, not necessarily. There used to be a strong theory that women with polycystic ovarian syndrome are at increased risk of miscarriage. That has failed to be substantiated. Obviously, if you are older with endometriosis, or you might be overweight, then they independently affect your ability to carry a baby. But polycystic ovarian syndrome and endometriosis per se should not increase your risk of miscarriage. What you have to remember is if you get pregnant with IVF, you're a 38-year-old, 40-year-old, 32-year-old woman having a baby. IVF doesn't increase your risk of miscarriage. It doesn't give you risk of fetal abnormalities or anything abnormal. What gives you an increased risk is the age at which you had your IVF. So if you're 40 and pregnant with IVF, you've got an increased risk of having a miscarriage than if you're 32 having had IVF. Generally, there are always exceptions, but that is a general rule.
Sarah's just asked here, and she's right about ubiquinol. Ubiquinol is the best form of coenzyme Q10. So, Sarah, yeah, you are correct in what you're saying.
Would ICSI help my chance of success? Well, that actually depends on why you're considering ICSI. If during the course of your investigations, the couple have been found to have a poor sperm count, then ICSI is absolutely the way to go if the count is particularly low. And I remember when I first started off in IVF before the advent of ICSI with low sperm counts, there was very little we could do in the IVF field. But once we discovered that we could actually inject a single sperm into an egg, ICSI, which is intracytoplasmic sperm injection, that revolutionized fertility problems due to poor sperm counts, and you can get very, very good chances of success. But using ICSI per se when there's not a sperm problem generally is of little benefit, unless your doctor has discovered something else that might be some sort of egg sperm interaction problem, or that you might have a thicker outer coating of your egg, or indeed you just got unexplained failure of fertilization with a good sperm count and a good egg count. It may be that micro injecting a sperm, forcing a good quality sperm into your egg may be of help. But as with all these things, you really need to speak to your own doctor, who will give you the time. He's got all your background, and he will be able to advise you whether ICSI will be good for you before you embark on that. And then, of course, the decision will be made jointly between you and your gynecologist.
There's a question that's come in here, Charles. It's about, is there, from Jess, anything I can do to improve the quality of my eggs? I've had a miscarriage from my first round of IVF, age 36.
What would you say to that then, Zita?
Well, I would say it's really, it's really unfortunate your first round resulted in a miscarriage. And I think there are things you can do to improve the quality of your eggs. I know that many doctors don't believe this, but I do think the environment in which the eggs are growing are affected by your lifestyle. So if you're drinking, if you're smoking, if you're eating lots of processed foods, it's not going to be great. So I would advocate vitamins and minerals, a multivitamin and mineral, an omega-3, some coenzyme Q10, and a good diet, the best diet that you can do in sort of preparation. But it's bad luck this first time round for her, having a miscarriage, and it's common as well.
Yeah, and I would say, and miscarriage is a much misunderstood condition, and people undervalue the trauma that a miscarriage can have. And what you have to remember for the miscarriage is that your brain doesn't recognize you've had a miscarriage. Your brain thinks that you've lost a baby, and you have to, and that's why you feel so bad, and that's why you have to grieve to get over these real traumatic. I mean, it's bad enough going through IVF, but then to get pregnant and miscarry, that's really desperate. However, you got pregnant, and that's good for the future. What I would say that is slightly different to Zita, although I agree with her in principle, eggs are eggs. You can't make them better, but you can stop them from getting worse. And all those things that Zita has said will certainly slow the rate of deterioration as to and growing them in the right environment, or the developing in the right environment. That can only be of benefit.
Yeah, I think as well, Charles, women don't really don't understand that miscarriage is more common. Once they've had a miscarriage and they start asking around, they realise that it is more common than they think.
Oh yes, cotton. Yeah. And even women who've had 3 or 4 babies and they have a funny period, and they normally have regular periods, and they have a funny period, and then they go, oh, that was a bit strange. The chances are it was probably a very early miscarriage. It's a very common cause of menstrual upset in fertile women. There's a question here: is it common to get no eggs at polycystic ovarian syndrome? It can happen. It's unlikely, and there is usually a good reason. And if you fail to get pregnant in your first cycle because you've got no eggs, then your doctor should be able to look at the situation and what happened. Was there something in the stimulation? Was your trigger injection a little bit wrong? Was the egg collection too early or too late? So there are lots of reasons why there could be no eggs collected. It's unusual. Very, very occasionally it can happen, but as I said, it's unusual, and usually there's a remedy. Zita, is there any hope for women who are almost 40? This applies to you. It applies to you.
What, getting pregnant?
Well, no, that's the question. Is there any hope for women who reach the age of 40?
Yes.
I presume it is getting pregnant. There's loads of hope for women of 40. Best years ahead.
Loads of women get pregnant over 40. Lots of women do. Again, it's dependent on your egg reserves, isn't it? But, you know, many women get pregnant at 40.
Yeah. The only thing that I would say for women who have delayed their family, or who have only met Mr. Right in later on in their reproductive careers, then don't try too long, because you know, you have got 40-year-old eggs. They won't be as fertile as they were when you were 30 years old, even though you didn't want to use them when you were 30. So don't wait the standard 1 year. If you want to have a baby and you're 40, seek advice early, because the earlier you go, the better is your chance of success.
But the hard thing for women, Charles, is when they meet their Mr. Nearly Good Enough, a man's likely to run for the hills when on the second date a woman wants a baby. So it's difficult, isn't it?
Yeah. There must be a technique. There must be a technique. Right, we're nearly out of time, Zita. That's gone quick. Goodness me. But are there any key points that you would like to make regarding polycystic ovarian syndrome and endometriosis, Zita, that couples can take away from this?
I think looking at your lifestyle, looking at your weight, as you say, getting the proper tests and investigations. You know, if you've got heavy periods, making sure your iron is okay. Vitamin D, omega-3 are all important, very important. Brilliant.
Well, thanks again, Zita. That's been great. Any unanswered questions, Zita and I will be around, and we can, if you pop them on an email, we can answer them later. I'm back off to care in Liverpool, and I hope I'm not too late. If ever you need help and you're in the region, then we're here, and the same with Zita in London. So thanks for watching. Okay. We'll see you again soon, and Zita, I'll see you soon.
Okay, Charles, take care. Bye-bye.
Bye. Bye.